Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews with NP Strategy, here in the studio today with Matthew Roberts, a Nexon Pruitt healthcare attorney. Matthew, good to be with you.
Good to see you.
Matthew, we often see employment and healthcare issues together.
That's true. When we do work for hospitals are usually one of the largest, if not the largest, employer in the community. So how they manage their workforce is usually reflective of best practices and what's happening in the employment world outside of that community. So it's interesting to track the trends that flow through employment into healthcare. They go together.
They do go together, and that's going to be our topic for today. Joining us is Juana Slade. She is the Chief Diversity Officer and the Director of Language Services at AnMed Health. AnMed is a 461-bed acute care hospital in Anderson, South Carolina. That's in the upstate. Juana directs the DEI initiatives and language and interpreter services at AnMed, which is South Carolina's largest not-for-profit health system. Juana, thank you so much for joining us today.
Delighted to be here. Glad to talk about my passion.
I can see it in your face already. And you do have a rich career in DE&I and healthcare. Can you talk a little bit about your background as we get started? Both just prior to AnMed and then outside of your career at AnMed.
Sure. I had the opportunity of working at another hospital system here in the upstate, and we established a program there, a diversity initiative there, based solely around a misunderstood, misinterpreted article that ran in the local newspaper. And so a team of us were assigned to work with an administrator at the time and make the decision that we needed to make on behalf of our hospital system to make sure that we were sending the right kinds of messages about diversity, health equity, and inclusion. At the time, we were only talking primarily about the workforce, and that would be diversity and inclusion. So that experience gave me the opportunity to contribute as a volunteer to that organization. And 4 or 5 years later, I received a phone call and had the opportunity to come to AnMed Health. And at the time, we were the second health system in the state of South Carolina to see the value in D&I and to actually dedicate full-time resources to that work. And I'm sure we'll talk a little bit more about the evolution of health equity into our work, thus DEI.
Well, Juana, you've been at AnMed for 21 years, and as you mentioned, AnMed was the second hospital to hire a diversity officer. Can you talk a little bit about what your career at AnMed has been like and how AnMed, presumably through your leadership, has become a leader in this DE&I initiative in the healthcare space? Sure.
I think in the broader diversity environment in our industry, there are a couple of things that are key. And number one, that would be finding the way to connect the work of diversity, equity, and inclusion to the bottom line of the organization, to the product, if you will, to the service. And in our case, the health and health status of the community that we are privileged to serve. The other thing that's critical would be leadership. Making sure that this is not just the flavor of the month, that we are not just making a decision to help people kind of do the right thing. We hope that, as the picture says over my shoulder, we do unto others as you have them do unto you. That's not the primary purpose for diversity in healthcare or diversity in the workplace. And so having the leader that understands that this is about separating yourself from other players in the market or other individuals or systems that may be selling what your product happens to be. And as I said, in our instance, we're talking about healthcare. We want to be the employer of choice, not because we're the only healthcare system in our primary and secondary market, but we want people to choose to come to work here. We want our patients to come to us because we can connect with them irrespective of what their differences happen to be, so that again, they too are making choices about coming to us as a provider rather than coming here because we are the only thing available.
You mentioned at the beginning how you began your career really by helping out with an article, news article that went wrong, and you married your passion here with helping. Over time, what have you seen are some ways that employers can identify issues that need to be addressed, whether it's DE, health equity, or I, inside the organization or in your service?
Sure, I can give you an example in both the diversity space, the equity space, and the inclusion space. Let's start with diversity. I think if you can take a look at your workforce and look at those individuals, purely looking at them based on race and ethnicity, you're able to find out if in fact your organization mirrors the market that you serve. In our industry, that usually it's pretty fair and pretty appropriately distributed. But the real difference is when you look at those individuals who are making the leadership decisions on behalf of that organization, how do those individuals or those representations, how do those persons compare to the makeup of your primary market? That's kind of diversity in general. Then when it comes to equity, we now want to make sure that we're looking at patient outcomes that are stratified both by zip code and perhaps by race and or ethnicity. Are there differences in the outcomes and health experiences of those patient populations? Are you collecting your patient experience responses? Are you collecting them and then taking a look at who those individuals were? And if you are able to stratify them, can you find differences perhaps in a particular area? Are there differences in response? Are there differences in experience based on the race of the patients who would provide those responses to you? And then finally, around inclusion, it sounds a bit trite, but I often say that just because I'm in the room, it doesn't mean that I'm included in the discussion. And so we want to make sure that in healthcare, we're looking at individuals before they make the decision to come to work at our system. We want to make sure that those individuals have a chance, whether they're in middle school, whether they're in high school, whether they are considering an allied health career, whether or not they're considering a career as a provider. Are we creating those opportunities across the board? Are we including all people who could perhaps either use our service or certainly chart a course as a healthcare provider or support individual?
Right. Juana, hospitals, communication within hospitals is important. It's vital to the delivery of healthcare. Can you talk a little bit about AnMed's language and interpretation services, which has become a lot more important in the last decade, I presume, than it ever has been?
Back to the one of my opening comments, and that's the comment around leadership. We've had a language services strategy in our organization since 2004. And I believe in 2004, when perhaps it wasn't as perceived as important, I was given the opportunity to come and build a program that allowed me to take the time, take the resources, build the right kind of protocol, if you will, that would allow us to make decisions that were appropriate, that would allow us to comply with federal law. And federal law says that as recipients of federal funds, which hospital systems are, we are required to provide meaningful access, regardless of race, gender, or sexual orientation. We need to make sure that those services are available. And so I had the benefit of time to very slowly build that service, those programs here that allow us to track a person's language, to make sure that every single time that person who speaks a language other than English, that person has the support that they need. Now, here's what oftentimes we misunderstand about that. We are an industry of risks, and so we take risks every single day. If a provider cannot take confidence that his patient or her patient understands and can contribute to his or her care, they're taking a risk. And certainly you would imagine that in an organization where 95% of us or 96 or 7% of us are English speakers, we're taking a risk in providing care to patients when that patient does not also speak English. And so it's important for us to have a system, a process in place that allows us to take confidence in that language capacity of the interpreter, that we can take confidence that the documents that are being translated on behalf of our patients are accurate so that we can mitigate that risk. So it's not about giving away something to individuals who perhaps should speak English, but it's about making sure that we are protecting and mitigating the risk to our organization. That year in 2004, when we started, we had roughly 4,000 encounters. This year, well, last year in the midst of COVID, we had 24,000 encounters. Wow. Those were 24,000 times that we could have gotten it wrong. And so what we want to do is to make sure that we are supporting our organization and that we are providing our staff, our medical staff, support individuals, and our patients. We're providing them with a communication tool that allows them to interact with each other accurately, every patient, every time.
You mentioned the pandemic that both illuminated and widened healthcare disparities. What did you see over the course of the pandemic, and then how was AnMed able to respond?
I really and truly am fortunate to work for an organization like AnMed Health. We truly try to think through processes, and we think about not only what we need to have in place, but also what our patients need. Our medical group did an amazing job in standing up an immediate response to the pandemic. We pivoted from in-person care rather to telemedicine in an extremely short period of time, but it's because we have kind of this collective attitude around working together and working as a team. We made sure that we were having conversations that in some instances might have been pretty difficult to have as it related to the outcome of our patients relative to the pandemic. You were exactly right. The pandemic allowed not just AnMed Health, it allowed the entire country to acknowledge that there are different health experiences, and unfortunately, many times those experiences are different for people in rural communities, women, and for children. We can't pretend that we don't know. Once you know, you know. Once you see it, you're aware, and the pandemic allowed us all to see it.
Juana, what do you think if AnMed is one of the largest employers? What do you think their role is to promote what you've done internally with respect to DE&I externally within the community, and to be a leader for other employers with the things you've done over the last 2 decades that you've been there?
It's our responsibility. We need to be a leader in every regard. I think we've got to be a leader in the midst of tough conversations. There are marginalized people within our primary market, and many of those individuals, unfortunately, are very close to, actually physically very close to our emergency room. Those experiences are very different. When we think about the individuals who live in the zip codes that don't necessarily have the access to primary care, and they don't have the resources to pay for primary care, even if they lived near primary care, it's our responsibility to try to figure out how do we address the social determinants of health. Research shows that a hospital healthcare system only impacts about 20% of a person's health status. The other 80% happen outside of the walls of the health system. And so we have a major role. Not only is it our responsibility, as I said earlier, to mitigate risk, but it's our responsibility to try to reduce cost. How can we take care of individuals, of course, who don't have the assets and the resources to provide their own care? How can we create an environment that allows them to be healthier in their lifestyles, that allows them to even consume healthy foods on a regular basis? I mean, when I think about many of those same communities that are high utilizers of our services in the emergency department, when you just think about the types of food that they have access to, it's a quite different experience just 4 or 5 miles up the road from the emergency room, where there are walking trails, where there are restaurants, where there are grocery stores, and there is access to healthy food. It's our responsibility to shine a light on those kinds of conversations and engage all of us, even in those topics and issues that might be uncomfortable. Or in some instances, folks may say, well, that's not the hospital's role. You said it yourself. We are the largest employer in Anderson County, and it's our responsibility to have those conversations, those tough conversations.
What do you think about the trend of going to where the patients are? So they're not coming to the hospital, but they're going to them through using technology, using some outreach services. A lot of times preventative, these are preventative measures to try to keep people, ironically, out of the hospital.
Yes. And I think that part of that requires the intelligence, the knowledge of the hospital system to know what are the chronic conditions in my primary market? What are some of the challenges that I have, and how can I take assets to those communities? I think there are many hospitals across the country that understand the power of the community health worker. A community health worker brings credibility to the hospital system. Oftentimes we like to connect with individuals who look like us, or individuals who may have similar experiences. And so having a community health worker to be the broker, if you will, on behalf of the hospital system certainly does help. One of our strategies in language services, it's certainly a comparative example. We have a protocol that helps us decide when we need an in-person interpreter, what encounters might be best if we're using video to have conversations just as we are here, or when is it appropriate? What kinds of encounters can we simply use the telephone for? And I think when we apply that same kind of logic to the value of connecting with people where they are, as I said earlier about the pandemic and the health disparities, we found a way to turn very quickly and realize our providers needed to connect with their patients, and it was not going to be for the foreseeable future of the traditional in-office visit with a physician. And so it's that same kind of thinking that we've got to continue to do, looking for those opportunities to do our work differently, just as effectively, just as equitably, just as efficiently, but it has to be differently.
Mm-hmm. Speaking of the community, you are involved in a lot of organizations, and they tell me that you were recently appointed board chair for the Alliance for a Healthier South Carolina. Can you talk a little bit about your leadership in this organization and how it addresses the healthcare disparities?
Well, I am the immediate past chair of the Alliance, and the thing that is so interesting about that, I became chair of the Alliance at the onset of COVID. I never got to convene an in-person meeting. The 2 years of the depth and breadth of the work that we did during my 2-year term was all done virtually because we were in the midst of a once-in-a-century pandemic. Just as with our own organization and health systems across the country, we realized that the work couldn't stop because we had run into this thing called COVID-19. And so it allowed all of us who are involved in the Alliance, it allowed us to recognize that the work had to go forward, that we would have to make sure that we were addressing those issues that were most important, those social determinants that were most important. We had to figure out a way to continue that work despite the pandemic. The Alliance is a group of 60 entities from all across the state of South Carolina who simply see value in finding ways to connect, to catalyze, and to convene conversations around health and health disparities. So the social determinants of health led us to create the Alliance. I think it was formed in 2015 15 or 16. And since then, it has evolved over time. And we've grown from about 30 organizations to about 60 organizations.
Well, I'm glad you
Impressive.
formed before the pandemic, right?
Right.
Because you were in position
And
then.
yeah, and expanded the services. It's impressive.
Our time has flown by, and I found our conversation fascinating. And I've made some notes because I think that there could be follow-up with us
Yes, I think so.
for you on a couple of things. But Juana Slade, thank you so much. Chief Diversity Officer and Director of Language Services at AnMed Health. You have been doing a good work for a couple decades, and thank you, and press on.
Thank you for having me.
Matthew, I did not think about patient outcomes in including with disparity.
Yeah, so the DE&I initiatives are beyond hiring and firing. And COVID, I think, exposed that. And healthcare systems are finding that out because they're treating the whole person and they need to understand everything about the person to get the best result.
Yes, well, it's fascinating, and I'm sure that they will learn a lot just from talking to people and getting, honest feedback.
Sure.
Makes me think I should fill out the form next time I go. Right. For those of you who joined us today, we hope you enjoyed this conversation and learned a little bit more about DE&I in the healthcare system. If you have any ideas for us for taking the pulse, shoot them our way. We love to hear from you who listen and watch. And on behalf of the entire team, thanks for joining us. We look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences podcast.